This is Dr. Bev Knox, and today's topic is in regards to female genital cutting and mutilation. Today, a worldwide sexual health controversy rages over female genital cutting, also known as FGC, and female genital mutilation. So, FGC is practiced in many African nations, as well as in several countries in the Middle East and among Muslim populations in Indonesia and Malaysia. According to the World Health Organization, 140 million girls and women worldwide have been subjected to these procedures, 92 million of them in Africa. Typically, FGC is performed on girls between infancy and age 15. Often, it is performed by a native woman without anesthesia or without any sanitary conditions. Female genital mutilation is practiced in several forms, depending on the customs of the particular culture. The simplest is called clitoridectomy, the partial or total removal of the clitoris classifies this as type 1. Excision type 2 involves the partial or total removal of the clitoris and the inner lips. The most extreme form is infibulation, which is the type 3, in which the clitoris and all of the inner lips are removed. Part of the outer lips are removed, and the raw edges of the outer lips are stitched together to cover the urethral opening and the vaginal entrance, with only a small opening left for the passage of urine and menstrual fluid. The World Health Organization states that type 4 refers to all other female genital procedures for non-medical purposes, including nicking or piercing, which is favored by some as preserving the tradition but injuring the body the least. The term female circumcision is also used, although its definition is less clear. Generally, it means the type 1 procedure. Now, all of these procedures pose health risks, and infibulation creates especially severe problems. Hemorrhaging may occur, leading to shock and even death because of the unsanitary conditions present during the procedure. Now, the same instrument may be used in turn on multiple girls, so HIV and hepatitis B can be transmitted. A common problem is that the pain of the wound is so severe and the stitching so tight that the girl avoids urination or cannot urinate properly, leading to urinary infections. A tightly infibulated woman can only urinate drop by drop, and her menstrual period may take 10 days and be extremely painful. Women who have undergone this female genital circumcision are at higher risk of infections such as herpes and bacterial vaginosis. The sexual and reproductive health consequences are no less severe. Infibulation is an effective method for ensuring virginity until marriage. But on the wedding night, the man must force an opening through stitching and scar tissue. It is painful and may take days. A midwife may be called to cut open the tissue. Orgasm would be only a remote possibility for a woman whose clitoris has been removed. Infibulated women have a substantial risk of complications during childbirth and of newborn deaths. Female genital cutting has declined in some nations such as Sierra Leone, where the prevalence has gone from 96% in older cohorts to about 70% in younger cohorts. Villages across Senegal have pledged to end the custom. Nonetheless, it persists in many places. If the procedures are so harmful, why do people continue them? Why do girls submit to them and even ask for them? And why do their parents permit or even encourage it? The answer lies in the complex and powerful interplay of culture and gender. Infibulation indicates not only virginity, but also a woman's loyalty to her culture and its traditions, a particularly sensitive issue for people long dominated by European colonizers. A woman who is not infibulated may not be marriageable in these cultures, in which marriage is the only acceptable way of life for an adult woman. When those are the rules of the game, it is less surprising that girls submit or even want to be circumcised, and that their parents require them to do it. Some communities may also hold certain beliefs that make these procedures seem necessary. Some Muslims mistakenly believe that it is required by their faith, although it is not mentioned in the Quran. Research also shows that the more empowered women are, the less they favor female genital cutting. Now, female genital circumcision raises a number of dilemmas in North Americans. In universities, we generally encourage the approach of cultural relativism, an openness to and appreciation of the customs of other cultures. But if we apply standards of cultural relativism, we should say, great, if that's what those people want. But should there be limits to cultural relativism? Can one oppose certain practices that pose well-documented serious health risks, even though they are popular in the culture? Well, medical personnel in North America face these difficult dilemmas. Immigrant women whose daughters are born in North America may request that a physician perform this procedure, knowing that the procedure will be far safer if done by a physician in a hospital. Should the physician comply, knowing that the realistic alternative is that the procedure will be performed by an untrained person from that culture under unsanitary conditions? On a more hopeful note, a grassroots movement of women that is dedicated to eliminating these practices has sprung up in a number of African nations, including Kenya, Gambia, Senegal, Sudan, Somalia, and Nigeria. And some surgeons in Western nations are developing reconstructive surgeries to restore anatomy and function of women who experienced female circumcision. Now, scar tissue is removed and the clitoris is uncovered. These procedures seem to be effective in reducing pain and restoring pleasure. Several points help to put matters into perspective. First, only about 15% of cultures that practice female genital mutilation do the severe form. Second, far more cultures practice male genital modifications than female genital modifications. Third, currently, there is a cult in the United States that advocates genital surgeries, such as removal of the inner or outer lips, because they believe that the vulva is more beautiful and erotic that way. More broadly, genital plastic surgery has become widely available and is raising controversies in the medical community. For example, some women want to have their inner lips trimmed, saying that they don't like the appearance of their natural ones and that surgery will improve their self-confidence. How should a surgeon respond to this? Would education and psychotherapy achieve a better result? And why are these genital plastic surgeries legal in Western nations where female genital mutilation is prohibited? Something to think about.